Okay, guys, we continue our lectures in propedeutics of internal disease. I hope lectures will be delivered weekly according to schedule. So, first of all of you who are present, please write your name and group number on the wall in ВКонтакте, not in the chat for lecture, but on the wall in ВКонтакте. I will check. You should write your name and group number at the beginning of lecture and at the end of lecture. So all who will be missing, they should write some paper about this lecture. That's why it's better just to present yourself than to fix yourself on the wall in ВКонтакте. Okay, today we'll talk about gallbladder and biliary system. Gallbladder and biliary system. So I hope you remember anatomy. You remember anatomy. So bile produced in the liver, and through bile duct, liver pass to intestine, through intestine, and main task for bile, main function of the bile is to help in digestion of the fat. Actually, bile contain no enzymes, but we need bile to emulsify fat, because you know that fat is not soluble in the water. And if you eat some fatty food, it just stays in big particles. What for we need bile? Bile creates small drops from big drops of fat in intestine. And that's why surface for digestion, for enzymes, increase many times. And that's why bile very important for digestion of the fat. Bile produced 24 hours. Bile produced 24 hours. But we need bile only 3 times per day when we eat something. That's why bile which produced continuously, we have some reservoir which is known as gallbladder. That's why normally what happened when bile produced between meals, bile collected in the gallbladder, and concentrated, because gallbladder capacity is only 50-70 milliliters, and liver produce about 1.5 liters of bile every day. That's why for each meals we need at least half a liter of bile. But capacity of gallbladder is only 50-70 milliliters. How it works? Actually, the reason is that in gallbladder we have concentration of bile in 10 times. It means that 50 milliliters of bile in gallbladder equal to half a liter of bile which produced by liver. That's why each time we have sufficient amount of concentrated bile to digest fat, to help digestion of fat, Okay, let's start talking about disorders. First disease we'll talk about, this is gallstones. Gallstones or cholelithiasis. So, gallstones may be present at any age, unusual before the 3rd decade, rare before the 3rd decade. This is progressive increase in the presence of gallstones with age, but the prevalence is 2 or 3 times higher in women than in men, although this difference is less marked in the 6th and 7th decade. At this age, prevalence range between 25-30%. So, in elder people, up to a quarter of them suffer from gallstones. This is a very common condition. There are different types of gallstones. 2 principal types of gallstones disease occur. In Western world, about 80% of gallstones contain cholesterol. The second less frequent type of gallstone is pigment stones, being predominantly composed of calcium bilirubinate or polymer-like complexes with calcium and copper. Formation of gallstones is the consequence of cholesterol crystallization from gallbladder bile. You know that bile consists of three components. This is cholesterol, this is bile, salts, phospholipids, and bilirubin. Cholesterol, bile salt, phospholipids, and bilirubin. And appearance of gallstones, formation of cholesterol stones is the consequence of cholesterol crystallization from gallbladder bile. This depends upon two factors: cholesterol supersaturation of bile or motility of the gallbladder itself. Cholesterol supersaturation. Cholesterol is derived partially from dietary sources, but in addition is synthesized within the liver. Cholesterol will only crystallize into stones when the bile is supersaturated with cholesterol relative to the bile salt and phospholipid content. You know, it's very important to maintain balance between all components of bile, because bile salts prevent crystallization of cholesterol. And if we have some disbalance, for example, concentration of cholesterol increase, actually relatively it becomes too high compared with bile salts, and we have crystallization. This can occur as a consequence of excess cholesterol secretion into bile or because of a relative decrease in bile salt content. So again, either we have high concentration of cholesterol or decreased concentration of bile salt. Decreased bile salt content may be genetically predominant or occur as a consequence of bile salt loss. Gallbladder motility. Gallbladder stasis leads to cholesterol crystallization mediated by hypersecretion of mucin. What does it mean, stasis? You know, normally again, we eat 3 times per day, and each meals, gallbladder should contract and eject bile into intestine. If this motility somehow fail or decrease, bile stay in gallbladder for a long time. As a result, it's predisposed to crystallization of bile. So, risk factors for cholesterol gallstones. No, this is increase in age, I told you. This is sex. Female suffer more from male. Multiparity, we talk about women's. Obesity, rapid weight loss, diet, for example, high in animal fat, some drugs, for example, contraceptive pills, diabetes mellitus, ileal disease or resection. Why ileal disease or resection? Because bile salts, which produced or excreted with bile, absorbed in ileal part of small intestine, and then go back to blood, then go back to bile, and we have some circle. If we have disease or absence or resection of ileum, it leads to loss of bile salts, and relatively we have high concentration of cholesterol, disbalance between bile salts and cholesterol. As a result, we have crystallization of cholesterol and formation of cholesterol gallstones. Acromegaly treated with actreotide, liver cirrhosis. Now, you know, to remember, usually we use the rule of 4F, who predisposed to development of cholesterol gallstones. Rule of 4F, F character. What does it mean 4F? This is female, 40, fat, and fertile. Again, usually gallstones happened in women's in their 40s or later. Fertile means with children's, and fat, no, obesity. Not polite to say fat about women's, no, just to remember. Bile pigment stones. The major component of pigment stones is calcium bilirubinate with less than 50% cholesterol content. There are two main types of pigment gallstones, black and brown. Black and brown. Black pigment stones are composed of calcium bilirubinate and a network of mucin glycoproteins that interlace with salts such as calcium carbonate or calcium phosphate. Pigment stones are seen in 40–60% of patients with hemolytic conditions in which there is chronic excess bilirubin production. So mechanism is simple. Again, I told you that in bile we have bilirubin. In hemolytic anemia, for example, we have continuous production of extra amount of bilirubin due to damage, due to destruction of erythrocytes. As a result, concentration of bilirubin in blood increase, concentration of bilirubin in bile increase. Now, if we have overconcentration of something, it may lead to precipitation, to crystallization and formation of pigment stones. Brown stones. These stones composed of calcium salts, of fatty acids as well as calcium bilirubinate. They are almost always found in the presence of bile stasis or biliary infection. So again, if you have bile stasis, brown stones also may appear. Now let's talk about clinical presentation of gallstones. Clinical presentation of gallstones. The majority of gallstones are asymptomatic and remain so during a person's lifetime. What we are talking about. So these gallstones, they may just stay in gallbladder and produce no signs, no symptoms, and people even don't know that they suffer from gallstones. This is just founding. Gallstones are increasingly detected as an incidental finding either time of abdominal radiography or ultrasound scanning. Over a 10 or 15 period, approximately 20% of these stones will be the cause of symptoms, with 10% having severe complications. So what we are talking about, that only 20% of patients with gallstones present clinical signs during 10 or 15 years. And even only 10% having severe complications. So the main presentation of gallstones, this is biliary or gallstone colic. Biliary or gallstone colic. I hope you know the term colic. Colic, this is attack of sudden pain. The attack of sudden pain in abdomen, and usually we talk about kidney colic, that may be intestinal colic. No, and now we are talking about biliary colic. Biliary colic is the term used for the pain associated with the temporary obstruction of the cystic or common bile duct by a stone, usually migrating from the gallbladder. Now, despite the term colic, the pain of stone-induced ductal obstruction is one of a severe but constant pain which has a crescendo characteristic. So again, usually when we talk about colic, this is some sharp pain which increase, then decrease, then again increase, then decrease, like spasm. No, this is usually for intestinal colic. But for biliary colic, this is continuous, increasing, crescendo pain. Severe, constant, increasing, crescendo. Crescendo means increasing. Characteristic. Why pain appear? Again, if you see, usually gallstones, they just stay in gallbladder and bring no harm. But if for some reason these stones start migrating, they goes to the neck of gallbladder, and then they can go to common bile duct. And as size of gallstone usually bigger than lumen of cystic bile duct or common bile duct, they just block bile ducts. They scratch the wall of bile ducts. As a result, pain appear. pain appear again only when bile stone leave gallbladder and move to cystic bile duct or common bile duct. Many sufferers can relate the symptoms to overindulgence with food, particularly when this has a high fat content. No, so we're talking about that usually such attack happened after patient ate a lot of fatty food, for example. Why? Because fatty food, this is stimulator for contraction of gallbladder, and powerful contraction of gallbladder can move gallstones, and they move to the cystic part, then cystic duct, and then common bile duct. The most common time of day for such an episode is the mid-evening and lasting until the early hours of the morning. The initial site of pain is usually in the epigastrium, but there may be a right upper quadrant component. So you know already that gallbladder projection on the abdominal wall, this is so-called gallbladder point. Gallbladder point, this is point between right hypochondrium, edge of ribs, and edge of musculus rectus abdomen. In this angle between, again, lower edge of ribs on the right and upper and lateral edge of musculus rectus abdomen, this is point of gallbladder. But pain may occur in epigastrium and maybe in this point for gallbladder. That's why, again, not in all cases pain absolutely corresponds underlying organ. Remember that pain may be in epigastrium, but maybe in right hypochondrium. Nausea, vomiting frequently accompany the more severe attacks. Why nausea and vomiting happen? You know, this is reflex. If something happens in abdomen, our brain believes that maybe you are poisoning, you ate something wrong, and induce nausea and vomiting to empty stomach. Of course, it can't help. The cessation of attack may be spontaneous after a number of hours or terminated by the administration of opiate analgesia or spasmolytics, cholinelytics. So why attack may stop? Usually under pressure, which created by contraction of gallbladder, pressure which created by production of bile in liver, stone can move forward and finally leave bile duct, enter intestine, and when it go to intestine, attack finished. In some cases, stone can go back to gallbladder. Again, pain may stop only when when the stone disappear from actually biliary system, disappear from biliary ducts. More protracted pain, particularly when associated with fever and rigors, suggest secondary complications such as cholecystitis, cholangitis, or gallstone-related pancreatitis. Again, if stones stay for a long time, it may cause inflammatory process like cholecystitis or cholangitis or even pancreatitis, and in this case, pain becomes stay longer. So, if we are talking about cholecystitis, acute cholecystitis, initial event in acute cholecystitis is obstruction to gallbladder emptying. In 95% of cases of gallbladder, stone can be identified at the cause. So again, remember, if we talk about inflammation of gallbladder, in more than 95% of cases, you should find gallstones. Gallstones, main cause of inflammation. Now, such obstruction results in increase of gallbladder glandular secretion, leading to progressive distension, which in turn may compromise the vascular supply to the gallbladder. Now, again, if pressure in gallbladder increase, this pressure press on the wall, it compress vessels, blood supply decrease, then inflammatory response secondary to retained bile within the gallbladder happened. No, and infection is a secondary phenomena following the vascular inflammatory events. We have germs everywhere and they just wait. when we have some damage somewhere, germs start growing. And it's happened in gallbladder too. Usually gallbladder is very aggressive, and germs, they can't survive in gallbladder. Bile can kill germs. But in the case of obstruction, in the case of the damage of gallbladder, germs somehow manage to survive, start growing and causing inflammatory process, which we know as acute cholecystitis. Initial clinical features of an episode of cholecystitis similar to those of biliary colic, so it's look like as biliary colic. However, over a number of hours, there is a progression with severe localized right upper quadrant pain corresponding to parietal peritoneal involvement in the inflammatory process. So again, in case of cholecystitis, pain increase becomes constant because we have involvement into inflammatory process of peritoneum, that peritoneal involvement. The pain is associated with tenderness, muscle, hardening, or rigidity. So when you press upper quadrant of abdomen on the right side, right hypochondrium, you may feel some tenderness. You may feel tenderness, or patient feel tenderness, and you feel muscle hardening. The abdomen becomes hard. Abdomen becomes hard due to contraction of muscles which try to protect inflamed organ from your palpation. Occasionally, the gallbladder can become distant by pus, so-called empyema of gallbladder. Rarely, an acute gangrenous cholecystitis develops, which can perforate with generalized peritonitis. So inflammation is not benign. All inflammations in the abdomen can't be benign. Again, sometimes it may involve all walls of abdomen with necrosis. When we talk about gangrene, and this pus, this inflammation may spread on surrounding peritoneum, causing generalized peritonitis, and patient may die from generalized peritonitis. So investigations, how to detect gallbladders, biliary colic. So biliary colic as a consequence of a stone in the neck of the gallbladder or cystic duct is unlikely to be associated with significant abnormality of laboratory tests. So what we are talking about? Again, just imagine this gallbladder, and if this stone block somewhere in neck of gallbladder or in cystic duct, usually nothing serious happened with analysis, because bile from liver just directly go to intestine. We don't have problems with passage of bile. We don't have jaundice. Acute cholecystitis usually associated with a moderate leukocytosis and rise inflammatory marks. What we're talking about? Neutrophil leukocytosis, shift to the left, ESR, the erythrocyte sedimentation rate increase, just telling about inflammatory process, bacterial inflammatory process. Serum bilirubin, alkaline phosphatase, aminotransferase level may be marginally elevated in the presence of cholecystitis, alone even in the absence of bile duct obstruction. Liver is nearby, and all inflammations of gallbladder can somehow affect normal function of liver. That's why, again, even without bile duct obstruction, we may find some changes in liver tests. More significant elevation of bilirubin and alkaline phosphatase is in keeping with bile duct obstruction. Pictures. On the picture you can see gallbladder, and second arrow on the bottom show us big stone which block the neck of gallbladder. This is, you see this arrow, and this is big stone in the neck of gallbladder. And this is gallbladder. Common bile duct stones, or CBD syndrome. Classic features of common bile duct stones: biliary colic, fever, and jaundice. Biliary colic, fever, and jaundice. This triad is only present in the minority of patients. Abdominal pain is the most common symptom and has the typical feature of biliary colic. So what we are talking when we talk about common bile duct syndrome? Again, this is, you see, when stone block bile ducts somewhere here. So what happened? Bile from liver can't go to intestine. In this case, we have development of mechanical or obstructive jaundice. The mechanical or obstructive jaundice. Because, again, bile produced by hepatocytes, bile can be removed from liver through bile ducts. Pressure in bile ducts in the liver increase. It causes rupture of small bile ducts, and bile go back to the blood. As a result, in this case, we have rise of bilirubin, serum bilirubin, and you know already that it will be so-called direct bilirubin, or it will be conjugated bilirubin, because, again, main feature of mechanical jaundice, this is rise of conjugated bilirubin or direct bilirubin. This is synonymous. Also, this is rise of alkaline phosphatase. Also typical for mechanical jaundice. Again, if stone block bile ducts somewhere here in cystic duct, nothing happened, because bile from liver can just go directly to intestine and no blockage, no jaundice. Jaundice happened only in case of common bile duct syndrome, when stone block common bile duct. Jaundice is a variable accompaniment and is almost always preceded by abdominal pain. No, it's clear. First we have attack, we have pain, and then we need many hours for increased concentration of bile in blood. That's why first we have pain, only after a few hours we may see jaundice. A patient with bile duct stones may experience sequential episodes of pain, only some of which are accompanied by jaundice. In contrast to malignant bile duct obstruction, the level of jaundice associated with CBD stones characteristically tends to fluctuate. What do I mean fluctuate? To change. Why? Because, stone block common bile duct. But from time to time pressure increase and bile somehow manage to pass through these stones, by age of stones. And in this case, jaundice decrease. Then again, jaundice increase. If it's a cancer which compress continuously common bile duct, in this case we have continuously rise in jaundice. No improvement from time to time. Fever is only present in a minority of cases, but indicates biliary sepsis and sometimes associated septicemia. So again, if we have rise of temperature, we have fever in patients with abdominal pain, this is serious. It means this is inflammation, and inflammation of abdominal organs may lead to peritonitis and death of patients in few days. Physical examination. If the patient is examined between episodes, there may be no abnormal physical finding. So again, if we have bile stones without attack, without colic, usually no abnormal physical findings, nothing. But during a symptomatic episode, the patient may be jaundiced. One of features, the patient becomes yellow. Again, remember, only in common bile duct syndrome. If stone somewhere in cystic bile duct, no jaundice. Fever, maybe in case of inflammation. Tachycardia, this is just sign of inflammatory process. It may be tenderness in the right upper quadrant, varying from mild to extremely severe. Tenderness, you try to press and patient cry because pain may be rather severe. Laboratory tests. Rice serum bilirubin tends to be mild and often transient. Very high concentration of bilirubin almost always reflect complete bile duct obstruction. So again, bilirubin, and we talk about direct or conjugated bilirubin. Serum alkaline phosphatase, gamma glutamyl transferase, similarly elevated in proportion to the degree of hyperbilirubinemia. So this is just one more test which tell us that this is complete obstruction of common bile duct. Complications of gallstones. Acute cholecystitis, acute cholangitis. Now I told you already that blockage can cause damage, then poor blood supply, then germs, inflammation, and we talk about cholecystitis and cholangitis. Gallstone-related pancreatitis may happen. So pancreas is nearby, inflammation of choledog, inflammation of gallbladder, blockage of normal bile passage may lead to inflammation of pancreas and development of pancreatitis. Gallstones can occasionally erode through the wall of the gallbladder into the intestine, giving rise to a biliary enteric fistula. Passage of a gallstone through into the small bowel can give rise to ileus or true obstruction. Now, this is extremely rare case. What may happen when big stone press the wall of gallbladder for many years? It may cause damage of this wall. The wall is penetrated, and under this gallbladder we have large bowel or sometimes small bowel, and it may penetrate into small or large bowel and produce even obstructions. No, this is very rare cases. There is some evidence that gallstone associated with increased risk of adenocarcinoma of the gallbladder. No, it wasn't proved in big clinical trials. No, theoretically, yes. Continuous irritation of gallbladder may predispose to development of cancer. No, cancer of gallbladder also is a very rare type of cancer. Non-calculosis cholecystitis. Yes, sometimes we see a cholecystitis without gallstones. Almost 10% of gallbladders removed for biliary symptoms shown to have chronic inflammation within the wall but absence of gallstones. Now, such cases described as non-calculous cholecystitis. In most cases, etiology is not known but has been attributed to bile studies. Again, it's possible inflammation without stones. Why it happened, we don't know exactly. No, maybe due to poor motility. So bile stasis, accumulation of bile in gallbladder, and finally may cause inflammatory process. Chemical inflammation of the gallbladder may also occur from reflux of pancreatic enzymes back into the biliary tree, usually through the common channel at the ample of Vater. Now again, remember anatomy that common bile duct and pancreatic duct, they open in the same place of the intestine, which is known as papilla fata, and ample of Vater, and some kind of regurgitation may take place from pancreas to gallbladder. Sometimes bile may enter pancreas, causing pancreatitis. No, this is rare also cause for possible inflammatory process. Now, bacterial infection of the gallbladder has occasionally been recognized as the cause of chronic inflammation. Okay, that's all about biliary system. Next topic is the pancreas. Again, remember anatomy, physiology. The pancreas extends retroperitoneally across the posterior abdominal wall from the second part of the duodenum to the spleen. It consists of head, body, and tail. The head is encircled by the duodenum. The body, which forms the main bulk of the organ, ends in a tail that lies in contact with the spleen. The pancreas consists of exocrine and endocrine cells, making 98% of the human pancreas. So actually, of course, you know that we have exocrinic part which produce pancreatic enzymes and endocrinic part which produce insulin, for example. Exocrine function. The pancreatic SNSL are responsible for production of digestive enzymes. The main function of pancreas to produce digestive enzymes. And these include amylase, lipase, colipase, phospholipase, and protease, trypsinogen and chymotrypsinogen. You see that pancreatic enzymes can digest everything. Amylase to digest carbohydrates, lipase to digest fat, and protease to digest proteins. That's why pancreas is the most important digestive organ in our body. Inflammation of pancreas is known as pancreatitis. Classification. Pancreatitis is divided into acute and chronic. By definition, acute pancreatitis is the process that occurs on the background of a potentially previously normal pancreas and can return to normal after resolution of the episode. In chronic pancreatitis, there is continuous inflammation with irreversible structural changes. Acute pancreatitis. In the Western world, gallstones and alcohol account for the vast majority of episodes. Alcohol also has a high potential to produce chronic pancreatitis. The severity of the pancreatitis may range from mild and self-limiting to extremely severe with extensive pancreatic and peripancreatic necrosis as well as hemorrhage. In its most severe form, the mortality rises to between 40–50%. Just imagine, pancreatitis, who know about such disease, but mortality is 50%, more than some kinds of cancer. That's why acute pancreatitis, severe acute pancreatitis, this is extremely dangerous disease. This is causes of pancreatitis. If it's acute, again, this is gallstones, this is alcohol, this is infection, this is some drugs. In case of chronic, main causes, this is alcohol. This is trauma, hypercalcemia. You see that in chronic pancreatitis, number one cause, this is alcohol. In acute, gallstones and alcohol. Pathogenesis. This is some suggestion that the final common pathway is a marked elevation of intracellular calcium, which in turn leads to activation of intracellular protease. It's these activated enzymes which are responsible for cellular necrosis. So what we're talking about, that pancreas produce enzymes which can digest everything. But how pancreas survive in this case? Why these enzymes, such enzymes, never digest pancreas normally? Because pancreas produce enzymes in inactive form. This is proenzymes which activated in intestine. They activated in intestine. So, but in case of inflammatory process, in case of alcohol consumption, in case of biliary stones, what may happen? Through the mechanism of calcium activation or increased concentration of intracellular calcium, this activation may happen inside pancreas. Activation happened inside pancreas, and these enzymes, they don't care what to digest. They start digestion pancreas itself, causing destruction, inflammation, and as a result we have necrosis, cellular necrosis, which we see as pancreatitis. In the case of gallstone-related pancreatitis, it's believed stones occlude the pancreatic drainage and the level of ampulla, leading to pancreatic ductal hypertension. Such ductal or ductal hypertension has been shown in animal models to increase cytosolic-free ionized calcium. So again, what happened? Again, remember that common bile duct and pancreatic duct, they have the same opening in the water ampoule. And just imagine that some stone block this water ampoule. And not only bile has a problems to pass through, but pancreatic juice also has problems to pass through. And pressure rise not only in common bile duct, but also rise in pancreatic duct. Rise of pressure somehow activates calcium production and activate enzymes. As a result, we have the same pancreatitis, destruction, and so on. Alcohol also interferes with calcium homeostasis in pancreatic acinar cells. So alcohol has the same mechanism, somehow activate calcium, and calcium activate enzymes. It not just, alcohol is a toxin. Of course alcohol is a toxin, but on the level of pancreas it just activates enzymes which then damage pancreas. Clinical features. Acute pancreatitis is a differential diagnosis in any patient with upper abdominal pain. Upper abdominal pain, don't forget about acute pancreatitis. Pain usually begins in the epigastrium, accompanied by nausea and vomiting. You see, the same may happen in cholecystitis, also pain in epigastrium with nausea, vomiting. As inflammation spreads throughout the peritoneal cavity, the pain becomes more intense. Involvement of the retroperitoneum frequently leads to back pain. Now, we believe that for pancreatitis, pain typically happened in left hypochondrium. If we talk about gallbladder, this is right hypochondrium, pancreas, left hypochondrium. But for pancreatitis, in many cases, we find so-called upper abdominal pain, which occupies the whole upper abdomen like a belt. We talk about belt pain, because it surrounds the whole upper abdomen, anterior wall, posterior wall, lateral parts, like a belt. The patient may give a history of previous similar episodes or be known to have gallstones. An attack may follow an alcohol binge. So unfortunately, in many cases, acute pancreatitis, this is result of alcohol consumption, especially with fatty food, because both stimulate production of enzymes, activate enzymes, and after some holidays, we see patients with acute pancreatitis. Patients eat a lot of fatty food and drink a lot of alcohol. Now, in some cases, no obvious etiological factors. We ask patient and we can't find why it's happened. Physical examination at the time of presentation may show little more than a patient in pain with some upper abdominal tenderness, but not systemic abnormalities. In more severe disease, the patient may have a tachycardia, hypertension, be allegoric. No, this all tell about severe problems in the whole body. Abdominal examination may show widespread tenderness with gardening as well as reduced or absence of bowel sounds. We don't do so-called auscultation of abdomen. No, what we can find, this is not auscultation of lungs or auscultation of the heart. But if you apply your phanendoscope to the abdominal wall, you can find so-called intestinal bruising. There are some sounds which produced by contraction of intestine. It's normal. Absence of bowel sounds. This is extremely dangerous sign. This is alarm sign. It means that we have peritonitis with paralysis of intestine, and patient may die in few days. That's why absence of bowel sounds. This is severe or sign of severe complications of pancreatitis as peritonitis. Now, specific clinical signs that support a diagnosis of severe necrotizing pancreatitis include periumbilical and flank bruising. So we can see bruising. Sometimes the red spots on the abdominal wall due to destruction of vessels with enzymes. Because when we have destruction of pancreas, enzymes go to blood, they digest vessels. And appearance of such bruising around umbilicus, periumbilical, known as cooling sign. Flank bruising, so on lateral parts of abdomen, known as gray tonus sign. In patients with a gallstone etiology, the clinical picture may also include the features of cholangitis, in particular jaundice, because again, usually common bile duct pass through caput of pancreas, and in case of severe pancreatitis due to edema, it may compress this common bile duct. As the result, we can see jaundice. Diagnosis: blood tests. Serum amylase level is the standard laboratory test carried out to confirm the diagnosis. Because amylase, this is one of enzymes which produced by pancreas, and in case of destruction of pancreas, this enzyme go to the blood and detect it in the blood. We can detect serum amylase, and rise of serum amylase tell us about damage of pancreas, tell us about pancreatitis. And if this is measured within 24 hours of the onset of pain, elevation of 3 times the upper limit of normal is an extremely sensitive test. 3 times higher than normal within 24 hours from the beginning of the pain, sensitive sign, test confirming acute pancreatitis. Urinary amylase levels may be diagnosed as these remain elevated over a longer period of time. So this amylase, they go to urine, and we can detect urine amylase as well as serum amylase. Now again, few pictures. On the picture where is arrow, you see pancreas, dark, you see part of pancreas, meaning that this is necrosis. This is computer tomography. You see dark part of pancreas, this is necrosis of pancreas due to acute pancreatitis. Complications of acute pancreatitis. Necrosis, maybe abscess, maybe intestinal complications like paralytic ileus. It may be gastrointestinal hemorrhage. It may be hepatobiliary complications like jaundice, obstruction of common bile ducts. It may be systemic complications. You see that just remember, acute pancreatitis, this is extremely dangerous disease. It's treated in surgical departments, not in therapeutical or gastroenterological, because sometimes it needs urgent surgery. Very severe and dangerous disease. Long-term outcomes. The vast majority of patients with a mild to moderate episodes of acute pancreatitis will make full recovery of acute pancreatitis, and no long-term sequelae. Recurrent episodes of pancreatitis may occur, particularly if this has been any long-term pancreatic ductal damage. Patients with more severe acute pancreatitis may become pancreatic insufficient, both with respect to exocrine malabsorption and endocrine function as diabetes. And final topic, this is chronic pancreatitis. Etiology. In developed countries, by far the most common causes of chronic pancreatitis is alcohol, accounting for 60-80% of cases. You see, when people talk about alcohol, usually they believe that the main problem is liver cirrhosis, the damage of liver, but alcohol damage all inner organs, and one of such inner organs, this is actually pancreas. And again, main cause of chronic pancreatitis, this is alcohol consumption. Obstruction of the pancreatic duct because of either a benign or malignant process may result in chronic pancreatitis. Now we discussed this. If we have blockage or obstruction of pancreatic duct, it leads to increased pressure in pancreas, activation of enzymes, development of chronic pancreatitis in our case. Pathogenesis. Now again, possible common pathway for pancreatic damage is the inappropriate activation of enzymes within the pancreas. Again, the same. Enzymes activated in the pancreas instead of activation in intestine. Now, chronic alcohol intake believed to increase the level of trypsinogen relative to its inhibitor. Human trypsinogen has a propensity to out-activation, and any relative impairment or deficiency of inhibitor proteins will lead to an opposite enzyme activity and possible pancreatic damage. So the mechanism again is simple. Alcohol activates enzymes inside pancreas, and this causes damage of pancreas. Pathogenesis again. That intrapancreatic enzymes activity leads to the precipitation of proteins within the duct lumen in the form of plaques. So what we're talking about? That imagine that pancreatic ducts look like a tree. Small branches, then they collect it into bigger branches, and then to a big common pancreatic duct. And we don't know why exactly, but enzyme activation cause production of specific proteins which create plaques. And these plaques block small pancreatic ducts. These form a needles for calcification, also cause of ductal obstruction, lead to ductal hypertension and further pancreatic damage. This is self-maintaining process. Damage causes plaquing, plaquing causes damage, and as a result we have damage, total damage of pancreas. Clinical features. Pain is the most common presentation of chronic pancreatitis and is usually epigastric, often radiating throughout into the back. The pattern of pain may be episodic, with short periods of severe pain, or chronic, unremitting pain. Exacerbations of the pain may follow further alcohol excess, although this is not a uniform relationship. So sometimes patients tell that it's after alcohol consumption, sometimes not. During periods of abdominal pain, anorexia is common and weight loss may be severe. So no, it's not a real anorexia. Patient experience pain after meals. That's why patient afraid of meals, and as a result his weight decrease. Endocrine insufficiency may develop at any time, and occasionally malabsorption or diabetes are the presenting features in the absence of abdominal pain. So again, if no pancreatic enzymes, no digestion, proper digestion, and food can't be digested and absorbed. As a result, we have malabsorption. How we see malabsorption? Patient lose weight. It look like as he eat nothing. Jaundice, secondary to common bile duct obstruction during its course through the fibrosis head of pancreas, may also occur and may be a presenting feature in small proportion of patients. So jaundice may be not due to problems with some bile stones, but due to problems with pancreas. Investigation. Now again, serum amylase, lipase, significantly elevated in established chronic pancreatitis. But again, serum amylase tell us about damage, destruction of pancreas. But how we can assess failure of pancreas to produce enzymes? To do this, we detect so-called fecal elastase. Fecal elastase. This is enzyme which released by pancreas, and we can detect level of this elastase in feces. And actually it's decreased in case of severe pancreatitis. So fecal elastase, pancreatic specific enzyme, is not degraded in the intestine and has high concentrations within feces. Diminished levels may be detected in moderate as well as severe pancreatic insufficiency, and is probably more sensitive than other serum and fecal tests. So idea is simple. If no fecal elastase, again, the same pancreatic cell produce all types of enzymes. That's why if fecal elastase decreased, it means that all other enzymes, trypsin, lipase, amylase, also decreased. Now again, this is picture. This is picture of pancreas, and you see this white spots. This is calcification, nodules with calcium inside pancreas. That damage, necrosis, calcification, and it look like this way. If we talk about treatment, what we can do? Try to ask patients stop taking alcohol. We can give substitutional therapy. Now we have enzymes in tablets which patient can take instead of its own pancreas. Theoretically, if you give sufficient amount of pancreatic enzymes in tablets, we can avoid severe malabsorption and severe problems with patients. Okay, that's all for today. Please write again your name and group number on the wall in Vkontakte. We'll check. And if you have some questions, you can ask using the chat. Okay, if no questions, next lecture will be next Monday, in time. So lectures obligatory. So goodbye till next week.